Welcome back from lunch. Thanks for joining us. We're going to give it just another minute or so before we get started. Welcome, everyone. Thanks for joining. We'll be getting started in just a few. Happy Wednesday, Yolanda. Halfway through. I always say I'm never sure if that's good or bad. I'm excited for the weekend, but there's more to be done and not enough days left to do it. So we're happy to have you spending your Wednesday with us here. All right, we can go ahead and get started. Thank you, everyone. Good afternoon. Hope you enjoyed a little break and got some time to get something to nourish you. Come back energized and excited for the upcoming session, Recovery Innovations Roundtable, supporting people with serious mental health conditions, an expert panel discussion. I introduced myself at the beginning of the conference. My name's Ann Murphy, and I'm the co-director of the Northeastern Caribbean Mental Health Technology Transfer Center. I have the good fortune this afternoon to be joined by four of my colleagues who are all with me in the Department of Psychiatric Rehabilitation and Counseling Professions at Rutgers. They each come with a different background, different areas of expertise, and some real rich information to share with all of you. So to introduce you to the group, we have Dr. Amy Spagnolo. She's designed and provided workforce development initiatives for behavioral healthcare providers and supervisors for over 2 decades. She's the project director of the Academy of Peer Services, as well as the New York Peer Support Services Technical Assistance Center, or Peer TAC. We're really excited to have you with us, Amy. We have Dr. Michelle Zechner, who teaches, conducts research on aging and wellness, and focuses on interprofessional collaboration to improve the healthcare of people living with serious mental health conditions. She developed one of the first undergraduate courses on aging and psychiatric rehabilitation and is involved in workforce development initiatives for behavioral health and providers of aging services. She's the principal investigator of a federally funded project designed to improve the dental health experiences of people with serious mental health conditions. Glad to have you here, Michelle. We have Amy Banco, who's a lecturer, trainer, and implementation consultant at the Integrated Employment Institute, where she provides trauma-informed supported employment and supported education, training, and implementation support to community providers. Ms. Banco co-developed the first mobile outreach supported education program in New Jersey and serves as a co-investigator for several federally funded studies exploring supported education services. Her research focuses on occupational justice for people with mental health conditions and improving the social determinants of health for individuals in the public mental health service system. Her work is informed by her lived experience with a mental health condition, and she brings this perspective to her roles as an instructor, scholar, and clinician. Thank you for being here, Amy Banco. And finally, Earl Leach is a senior training and consultation specialist, providing training, consultation, and technical assistance to community support services provider agencies in New Jersey. He also provides training to mental health providers funded through the Washington State Healthcare Authority. He has more than 25 years of experience in service provision, management, and administration in behavioral health organizations in New York, New Jersey, Virginia, and Massachusetts. Prior to joining Rutgers, he served as the regional director for mental health residential services for a private, not-for-profit behavioral healthcare organization and worked collaboratively with county mental health boards and local professional advisory committees on alcohol and drug use in the northern region of New Jersey. We're excited to have you here, Earl, and the rest of the team. And I'm going to get us started and help facilitate here with some questions. So the first question to the panel is, in each of your respected areas, how are services responding to the needs of people living with mental health conditions? What are the promising and best practices and their related outcomes? How does this look now? How is it being responsive to the particular needs of individuals that you're seeing? So Earl, we're going to get started with you, and then we'll hear from the rest of the group.
Thank you, Anne. Community support services, I don't know how familiar you are with community support services, but certainly is an innovative approach to providing supportive living services, supportive housing services to people with a history of severe and persistent mental health in New Jersey. CSS, as we call it, consists of mental health rehabilitation services and supports. And the focus is on rehabilitation as opposed to merely ameliorating symptoms. So it's important to recognize that distinction. The hope that is that the service and the foremost element of the service is really about supporting people and ensuring that they strive to achieve and maintain valued life roles in those significant areas of their life, social areas, employment domains, and to maintain those valued life roles as a means of really achieving recovery, full, and we call it maximum community integration, and to really live a meaningful, purpose-driven life despite the challenges of mental illness. And that's significant in terms of it being a service that is really driven by the psych rehab principles and is basically focused on recovery principles as well. So that's CSS, as we call it. Some of the best practices and outcomes that we see is certainly really looking at that peer recovery support service that is an integrated part of it. It's one that we are continuing to grow in that area. It's person-centered and really have some planning tools that really promote that person-centered approach. There's lots of evidence-based practice that are significant in terms of it's really aligned with the principles of recovery, but CSS is really driven by evidence-based practices and principles. From IMR, illness management and recovery, to psych rehab, to cognitive behavioral strategies, to dialectical behavioral strategies, all of that encompass our approach and practice across CSS. In terms of how this service responds to the needs of consumers, more significantly, CSS is really about helping adults who live with behavioral health conditions to thrive and to find purpose and meaning in their lives and to live in chosen communities. So we're talking about really helping someone see their behavioral health conditions as a part of their full existence, yet they can strive to meet those aspirations, those goals, those desires in their lives with all the necessary supports and services that are indicative for their particular concerns. And this is, once again, a primary person-centered approach to providing behavioral health services. It's a psych rehab-based service, and it promotes recovery, full community integration, and improved quality of life. For us, CSS is not merely a service, but it's a way of enhancing the life of people who are, for the most part, profoundly underserved, but yet oftentimes have the greatest aspiration for what life can be for them in spite of mental illness or behavioral conditions. And that's essentially my take on the service that I think it's more than anything else, a absolutely necessary service for people, particularly in our community.
Thanks so much, Earl. Amy Banco, can we hear from you?
Thank you, Anne. Earl, what you said about psych rehab, the principles of psych rehab, it's very much represented in career services too. So I really appreciate your reflection on CSS and how it really empowers people to develop recovery aspirations and to achieve them. Thinking about the modality of career services, I do believe there's a certain aspect of intentionality in the design and implementation to truly meet the employment and education needs of people living with mental health conditions. It's crucial to note for context that career service isn't just a broad, vague term. It's actually a blend of two SAMHSA endorsed evidence-based practices, IPS supported employment that was developed by Becker, Drake, and Bond, and supported education, which was initially championed by Carol Mowbray, Karen Unger, and Anne Sullivan-Soyden at Boston University. These practices have evolved, offering an integrative approach for community-based, individualized, and time-unlimited career support services. These services are eligible to individuals who have a mental health condition, uh, who have a desire, right, to return to work or post-secondary education. And the services focus on this three-prong approach of skill development, resource linkage, and accommodation development. I think what's powerful about this integrated model, blending of supported employment and support education, is that the specialists are cross-trained to provide this seamless transition between employment supports and education supports based on the individual's needs, interests, their preferences, and values. And unfortunately, when I think about this piece of need, right, the need for career services is undeniably profound. When we look at individuals with serious mental health conditions, or what has been traditionally labeled as SMI, we see staggeringly high rates of unemployment, hovering around 80% nationally. Many folks in that public mental health service system experience chronic unemployment, meaning they've been without work for 12 months or longer. And when folks do secure employment, they are often underemployed, working in jobs that don't match their skills or their aspirations. When we think about the post-secondary education setting, students with mental health conditions face the highest rates of attrition across all disability groups. Their challenges really are with academic persistence, and that leads to dropout, right? And once they leave, what we see in the literature is they often don't return. So this cycle results in lower levels of educational attainment for individuals with mental health conditions, which in turn limits their access to high-paying jobs, right? Forcing them into the secondary labor market if they do find work. And these jobs, right, thinking about the characteristics of that secondary labor market, have lower wages, fewer benefits, or no benefits, right? Think about your first job. Did you have paid time off? Did you have vacation days? Did you get health insurance, right? Limited career mobility and short-term job tenure. So career services significantly enhances access and maintenance of those meaningful, normative developmental life roles like student and worker. And these roles are deeply tied to overall health and wellness, right? Thinking about the theme of the conference. We refer to these things as social determinants of health. Employment and education are foundational social determinants of health, meaning they directly impact a person's ability to access other critical social determinants of health factors, like stable housing, as Earl was talking about, community integration, and healthcare. So by providing these robust career services through supported employment, support education, we're addressing these essential social determinants of health, paving the way for hopefully long-term wellness for folks, especially these folks on fixed Social Security benefits, helping them to pave a pathway out of poverty and to build a life that's financially stable, personally fulfilling, and really addressing their overall wellness. When we think about outcomes in terms of these treatment modalities, high fidelity supported employment, we see employment rates upwards of 60% for people who are receiving those services. And for support education, we see that people complete their courses at higher rates. Unfortunately, there are no long-term or longitudinal studies to date exploring graduation rates for people receiving supported education, but that is actually what my dissertation is on. I'm in the process of exploring some of that data now. So hopefully, TBD, I will get back to you and let you folks know.
Looking forward to hearing those results, Amy. That's wonderful. So two services, housing that Earl is talking about, particularly from a community support services rehabilitation approach, and career services that are really looking at filling those important life roles, community participation, and really being a part of one's community. Amy Spagnolo, you're going to talk to us a little bit about peer services. So how are peer services responding to the needs of people with mental health conditions? And do they relate to these other community participation rehabilitation approaches?
Well, the short answer to your second question is absolutely. No surprise that I'd be here advocating for peer specialists across the array of services available in mental health settings. But to answer your first question more specifically, peer support specialists respond to the needs of people living with behavioral health conditions, both mental health and substance use, in a multitude of ways. So I'm here representing the Academy of Peer Services, which is the training, testing, and tracking platform for the preparation of certified specialists across New York State. But in addition to helping folks become prepared to get certified in this really critical segment of the behavioral health workforce, the Academy also offers training and community development for any person who's interested in peer support work, as well as supervisors. So while this is really specific to New York, it's an open source, open access set of curriculum that any agency across the country could check out, register for, and get some enhanced training for peer specialists and their supervisors at their agency. So I'm going to do a little bit of promotion of that by putting a link in the chat to the Academy, and folks can check out the course catalog and some of the other offerings. The peer support specialist workforce really consists of essentially frontline workers who are using their own lived experiences to support other people in their recovery from mental health and substance use challenges. And the workforce itself has existed in behavioral health and other fields also for several decades. But I'd say that over the past 10 years, we've seen a tremendous increased need, as well as a real proliferation of peer support specialists in the behavioral health workforce across a variety of settings, and working with people from a multitude of different kind of populations. Peer support services, for anyone who might be kind of interested in the numbers, are currently available in 49 states, with each of those states overseeing the credentialing or certification process, as well as the recertification or maintenance of the credential through a variety of training and testing modalities depending on the state. And there is no necessarily required national certification that will allow for the peer specialist to work in settings and also to bill for those services. It is largely state certified. So when I think about one of the promising areas of workforce development for peer support specialists, it's definitely specialization training. And in New Jersey, where we're from at Rutgers, we have offered a very recently developed specialization in crisis peer support specialist training for those peers that are working in crisis settings across the state. And we've gotten really positive feedback and wonderful participation from peer specialists who are working in those very challenging crisis settings. In New York, we've been offering 5 specializations as well as complementary learning collaboratives for nearly 2 years. And those specializations are older adult, justice involved, crisis, health and wellness, and supervision. So these specialization curricula were developed in collaboration with peer support specialists and supervisors, as well as the leaders of peer services across the state. And we modeled them, the curricula, after national practice guidelines and best practice guidance for peer support specialist competencies and work. And so I see that as a real advancement for peer support specialists across the country, because we recognize that the core competencies of peer support specialists are critical, but advanced training in some of the specialized populations really helps to complement the work that they're doing, because we recognize it's challenging work. So I guess to sum up the question, Anne, with my response, I think the impact of certification and specialization training combined is just a better prepared workforce that's positioned to meet the individual needs of people who are seeking and receiving peer services across the service delivery system.
Wonderful, Amy. That's great to hear about some of the new advancements and to see how your work is continuing to really support peers to do peer work, and really maintaining some of the critical aspects of peerness in that work and development. That's really exciting. So Michelle, coming over to you now. Your specialization is a little bit different from the others. It's not a particular practice. It's more of a population. So older adults with serious mental health conditions. So tell us a little bit about the population and about the services that they need and how they might be a little different from what the general mental health community might need.
Thanks, Anne. Yeah, I think that many of the services already mentioned, I'll talk about that in a moment, really are things that people aging with serious mental health conditions would benefit from. But I do want to talk about the population a minute because it may not be an area that many of us are familiar with. People aging with serious mental health conditions are likely to have had decades in the mental health system and experience significant health concerns. We know, and it's pretty commonly known, that people with mental health conditions are at risk for dying earlier than others. Estimates range anywhere from 12 to 25 years, but we're also learning that the population is likely aging faster than other groups. People who are aging with serious mental health conditions may have experienced the underemployment or poverty that Amy Banco was mentioning. They may have had challenges over the years with social connections or family connections. They may have had a history of using substances in the past or are continuing to use substances. They may have faced stigma and discrimination over decades. And all of these are social determinants of health factors that are believed to cause greater health problems and rapid aging. And these issues may be even more impactful for people from historically underserved groups. Therefore, the best practice is that we think of people who are in their 40s who live with a serious mental health condition as people who are aging. I know it's a little shocking, but it's something that I think we do need to think about. This is an area where the science is still emerging. SAMHSA recently published a good report that covers the interventions in science behind them, called Psychosocial Interventions for Older People with Serious Mental Illness. And I'm going to try to post that in the chat right now if you're interested in learning more. The best practices with people aging with serious mental health conditions have focused on a few areas like cognition and thinking, relationships, independent living, psychiatric symptoms, and healthcare concerns. These are interventions that have already been talked about a little bit, such as CBT or cognitive behavioral therapy, social skills training, and teaching self-management of health conditions. Assertive community treatment or providing comprehensive outpatient services that include a whole multidisciplinary team is considered a best practice with the population as well. Interventions have been combined, things like integrated illness management and recovery, which includes a focus on illness management, but also on physical wellness management. Another combined program is called the Cognitive Behavioral Therapy Social Skills Training Program, kind of a mouthful, but it's an approach that combines cognitive skills, social skills, and problem-solving skills. So these interventions are manualized and they're sort of connected together. There's another program out there called the Functional Adaptation Skills Training Program that's been researched and really focused more on independence and quality of life through community living skills like medication management, social skills, finances, organizational thinking, and transportation. Another program that is quite well known is the Helping Older People Experience Success, which combines skills training with preventative health care. Comprehensive services that address multiple areas, things like physical, emotional, social, even spiritual well-being, are also considered best practices for this population, as are efforts to support independent and community living. Many programs have demonstrated that identifying and working towards personally meaningful goals is helpful, particularly for older adults, which may be sort of new information. Outcomes have studied different interventions include improving negative and positive symptoms, or negative symptoms are sort of like the lack of motivation or difficulty engaging. Things like executive functioning or focus and attention on decision making, improving social relationships, connecting to a primary care provider, improving knowledge and management of chronic health conditions like COPD or diabetes. Some studies have also looked at people being able to successfully learn new independent living skills like managing money, taking public transportation, and setting and keeping recovery goals. A few other outcomes that have been examined have been trying to prevent people from premature nursing home placement and also preventing homelessness. I'll turn it back over to you, Anne.
That's great, Michelle. Thank you for that overview and some of the interventions and supports that are established thus far for working with individuals who are aging with mental health conditions. It really is quite hard to wrap your mind around people in their, 40s experiencing conditions that, many people, the general population, wouldn't typically be experiencing until their 60s or so, and it really does encourage us to shift the way we're thinking about individuals and when we need to start looking at some of those supports at such an earlier age. So thank you for that, Michelle. So I think that you all have given us a good overview of each of your areas of services and how those services work. Being that for the conference today, we're doing a little bit of looking back, looking now, and looking forward. I'm wondering if each of you can talk about what you see as the next steps, what's on the horizon for your services, or what do you think needs to be considered in the future related to each of your respective areas? We'll go back to you, Earl, to start.
Sure. I think like anything else, looking back from whence we came to get a sense of where we are, where we want to go, there's always that trajectory that we should be focused on. And as community support service continues to really promote and to support people in developing those skills, knowledge, and resources that are necessary to increase their capacity to be successful in living, working, loving, all that great stuff in the community. I think it's important for us to recognize from whence we came, as particularly for CSS, and that is out of the general supported housing modality or way of providing service, which is all about really helping people find tangible and viable housing settings. I think we move beyond that to the point where we see housing as part of that path towards living a meaningful and purposeful life. And thus, we look at other domains in that person's life to include socialization, recovery, career paths, and all the other encompassing elements or dimensions of one life that can really promote that quality of life. What we see on the horizon in terms of a service or a way of supporting those services or continuing to build on those services are, for New Jersey as a state, that great promotion of the integration of both behavioral and medical care, so that our folks can really access those services in a one-shop place, or at least in one means, so that there isn't that need to be having to be linked to multiple providers. I think that's so critical for folks who are living meaningful in the community to have the same kind of access to integrated care. Trauma-informed care is certainly a lens in which we are looking at our service and how people can benefit from that kind of thoughtful and compassionate lens, so to speak. We look at how community integration is also being scaffolded up by the state of New Jersey, in terms of there's a strategic plan to streamline those efforts to ensure that vulnerable folks and folks in our service are actually accessing greater opportunities for community integration. There's a fee-for-service model that is also being promoted, so that folks who are receiving service can have greater choice and can actually ensure that the limited dollars that is allotted to them are actually used on the service that is provided, and not simply that concept of all thrown into a bucket and hope that it works. It's about ensuring that those services are specific and they're paid for in that manner. And there's certainly innovations around career path development, to Amy's point, and we'll talk more about that. There is a greater sense that the pursuit of education and employment to enhance one's quality of life is not just viable, it's necessary. And it's also should be available and accessible to every single person that is desirous of accessing those resources. So those are some of the innovations that are prominent in CSS for what we see as a bright future for folks who are definitely in our services.
Thanks. So Amy Banco, Earl called you out, so we'll go to you next here.
Thank you.
What's
Thank
on
you,
the
Anne.
horizon for career services?
Yeah, so looking at recent developments in the field of career services, I think several key areas of need has garnered scholarly attention to ensure that I think career services continue to evolve in a way that is meaningful and really meets the diverse and growing needs of individuals with mental health conditions. So first, like the labor market in this country, the economy is changing. Certain college degrees may not translate into employment that allows for people to be financially self-sufficient. I have many friends, I'm sure you guys can think of your own social networks, who folks who've completed degrees, expensive degrees, and they couldn't find work. Additionally, traditional degrees are taking longer to complete. A 4-year degree is the new 6 or 7-year degree. So to address this changing landscape, a newer iteration of career service was developed at Rutgers University's Integrated Employment Institute that focuses on supporting students in career and technical education fields, or CTE. Right? These fields really offer a direct response to the shifting demands of the workforce, supporting entry and matriculation into hands-on training and certification programs for jobs in growing fields like healthcare, renewable energy, right, information technology, so that individuals with mental health conditions can really have a viable pathway to stable, high-demand careers with opportunities for growth. Again, when I think about what's on the horizon here at Rutgers, I'm working with my colleagues Brittany Stone and Ni Gao on expanding these CTE-focused career services, because how you provide support to someone in a CTE program looks different from those traditional 2 4-year degrees, right? So we want to make sure that those are accessible and tailored to the needs of these unique students. And I'll put into the chat a link to the Integrated Employment Institute and that CTE work for folks to reference in a second. There's also a lot of work being done in terms of transition age youth and young adults, or TEA. There's a lot in terms of helping this particularly vulnerable group navigate the complexities of late teen years to early adulthood as they concurrently are exploring identity development, right? And managing the onset of a mental health condition or an acquired disability. So really these specialized career services can support their unique needs, balancing education and work simultaneously, supporting positive identity formation, right? Preventing illness identity or that sick role, managing mental health symptoms, building long-term career plans and pathways. So these services, unfortunately, are very sorely needed. I'm sure a lot of folks here today can note that our nation is currently experiencing a growing prevalence of mental health conditions in younger populations. Examples of this work include folks at the University of Massachusetts, like Michelle Mullen, Marsha Ellison, Catherine Sabella, with projects such as HYPE and IPS for TAEA. Another critical component, and I think this goes back to Earl's point, is establishing the integration of career service into existing evidence-based practices, such as housing. One such example is RIST, Residential Intensive Support Teams, or first episode psychosis programs, right? So really getting these good career services into multidisciplinary models of care, helping those folks to really access employment and educational goals early on. I really think the future lies in making these the integration of these services seamless, so that employment and education are considered core components of mental health recovery from the start. The other thing that I want to reflect on is something that Earl had said in terms of trauma-informed approaches. And that's something that has definitely been on the horizon with career service development. This work, initiated by Dr. Kim User and further developed by Wei-Li Liu at Rutgers, acknowledges individuals in the public mental health service system have reported higher rates of complex trauma compared to the general population. And so, to Earl's point before, trauma-informed career services is just essential, really, to help mitigate the effects of trauma and trauma responses that we so frequently see people experiencing as barriers to meaningful life roles like student and worker, to the recovery overall, like Earl was saying.
Thanks, Amy. So interesting that you raised some of these integrated care models, particularly the early psychosis programs that have been developed. And one of the key components of those integrated services also includes peer support. So Amy, back to Amy Spagnolo here. What are you seeing? You started to talk to us a little bit about the specialization tracks that the Academy of Peer Services has established, but what else do you see coming up for peer services?
Oh, thank you for the segue first. That was expertly done, Anne. So much of what Amy, Benko, and Earl and Michelle are talking about relates directly toward, I think, an important advancement in peer support work, which is inclusion on the interdisciplinary team, not just the peer on the team, but generally one of the, critical components of the team is the peer specialist versus this ancillary position. So I think two areas of peer support services that should be considered for future development and expansion, or things that are on the horizon that come to my mind, are lifespan peer support implementation and implementation of that lifespan peer support, but in the more traditional behavioral healthcare settings. Because that's really where I think we need to see a shift to embracing the power of peer support and the value of its contribution to people's lives. And then the second part of that, I think, is a more increased focus on adequate training and communities of practice for supervisors of peer support specialists, because we know in particular in this segment of the workforce, the majority of supervisors of peer support services and specialists are not peer support providers themselves and haven't been and in many cases are not people who share the lived experience of a behavioral health condition. So the whole idea of like an apprentice model, which our colleague Joanne Forbes at Rutgers proposed, is out the window because you don't have the requisite experience and competencies to supervise a person in a role that you yourself are not already expert in. So opening the door to more supervisors versus closing it, but ensuring that they're trained and that they understand the value of the peer specialist on the team and what those practice guidelines are for the peer specialist to avoid peer drift. So in New York, we're working really closely with clinics to better implement youth, adult, and family peer support. There's a really clear mechanism for clinics to bill for peer services that clinic leadership and billing departments can become competent in order to sustain these services. And we've done some innovative work out of the Peer Services Technical Assistance Center, or as you mentioned, Ann, PeerTech, to design products to get implementation going. And one of those is an organizational self-assessment, which I think is definitely the first step in helping agencies that have not traditionally offered peer support services across the lifespan kind of take their temperature and see how close are we to being able to actually implement peer services. And then we've also created things like an array of onboarding and training products for peer support specialists. And we're really focused this year in particular on the supervision of peer support specialists workforce, which was a critical area I mentioned in answering this question. So I think that instead of having to, reinvent the wheel or start from scratch, there's a multitude of resources available for agencies and programs that are very interested in implementing peer support services across the lifespan. And there are organizations for youth peer advocates, family peer advocates, and adult peer specialists that the audience may want to tap into to kind of get a leg up on designing and delivering these services.
That's great. Thanks, Amy. Those are some exciting developments and some key areas of need that you all are focusing in on. So Michelle, how about you? What's coming up? What needs to be considered in services to support people aging?
Well, it's an exciting time, and I think that more than any of the other services, it's wide open. There's a lot of opportunity for growth. And Dr. Spagnola was talking about peer services and the certification specialist for older adults, peer support specialist for older adults. I think peer supports are vital to helping people age well, regardless of whether you have a mental health condition or not. But I think in our field, there aren't a lot of older adult peer specialists. So recruiting and training and motivating the peer workforce to help people age well is really a critical intervention that needs to be studied further and needs to be expanded in a lot of different areas. Some of the other areas that I'm very passionate about is the idea of multidimensional wellness. Many of us are probably familiar with the 8 dimensions of wellness that was created by Dr. Peggy Swerbrick, later adopted by the SAMHSA as a way to think about person-centeredness and how, like, the whole person and their wellness. A new model that we've been working on together is to use a new, to take those dimensions, but add a new dimension and thinking about developmental wellness or the ability to age well despite any condition that a person may have. What does aging look like for someone who may have been in the mental health system for decades? What purpose, what meaning can they draw? I think this is an area that's not been well studied. As providers, we can focus on the importance of aging well, helping people find new meaning, purpose, and perspective as they grow older, and even to manage some of those hard life transitions, grief and loss that come up. I don't know about you all, but many of the folks that I've served and worked with have died at very early ages. And so then we need to be talking about grief and loss at earlier ages, as I said, in the 40s. And the more that we look at these multidimensional areas, we're supporting emotional and physical well-being through looking at cognitive, social, environmental, financial, spiritual wellness. All these things are critical components of good quality of life and recovery and emotional and physical health. Another area that I'm pretty passionate about is a focus on physical functioning. And that's how people bend over, stand, walk, or take steps. It's not very sexy, I know, but having worked with folks, I see people having trouble getting up from off the floor, playing with their kids or their grandkids or their pets, or taking the 3 steps up to their apartment. It has a huge impact on things like that Earl is talking about in housing, how people function. So I think we really need to be looking at that. And we did a study and we found that people with mental health conditions are moving and functioning physically at about 20 to 30 years older than their chronological age. I'm going to say that again. People are moving 20 to 30 years older than their chronological age. So that means if someone's in their 40s and you're working with them, they're moving and functioning as if they're in their 60s or 70s, which has a huge impact on the kinds of services we offer, the supports that a person may need, and how we can just sort of basically work to address physical functioning and prevent problems. There was a study I recently read that showed that people even in their 30s were having problems with physical functioning. The last area that I want to touch on, which is a little more positive, is positive psychology. I think that using elements of positive psychology with people who are aging with serious mental health conditions is really, really important. And in aging, generally, we would call that positive aging, right? But that means the use of personal strengths, the concepts of grit, resilience, perseverance, even happiness. So all of those areas, I think, are future directions for this work and could fit well with our population.
That's great, Michelle. You keep laying on some heavy realizations here, but necessary ones. It's important that we recognize these things, even if they're things that aren't pleasant. And it's critical for us to keep those things in mind as we go forward. So I know we just have a few minutes left in our session, and if anyone has any questions for our panelists, please feel free to drop them in the chat or in the Q&A. We did also, I see Amy just provided her email address. I think the others are going to do so as well, so that if you're interested in connecting with them, I know I see the question in the Q&A about connecting with some of them. Please feel free to reach out to them via their email. All of the people on this panel are also at Rutgers in the Department of Psychiatric Rehabilitation and counseling professions. You can find us all there as well. So just before we go, and as you all are sharing your contact information, I guess I wanted to see if anybody wanted to weigh in on some of my observations, which were that each of you are talking about from your individual perspectives, I think, meaning and purpose in life, whether it be through connecting in community, living in the community in an integrated way at work or at school, or as a peer, supporting others, utilizing your experience, or functioning well so that you can continue to live and to live in an integrated way in the community as you age. So I'm just wondering, do you all have any other observations about some through lines that go through each of the work that you all are talking about?
What
Well,
comes to mind for
undoubtedly. How much time do you have?
Well, about 1 minute.
Fair
So
enough. Well, quickly, if I can, and I'll give Amy half of that minute. I think more than anything else, for community support services, our folks are impacted by all those issues, particularly aging in rapidly and aging in place and requiring those specialized skills and knowledge, and looking at the transition of aging from a positive perspective. I think it's important for us to all age positively and to know that we can age positively, and there are skills, knowledge, and resources that can enhance our capacity to do so. And I think ultimately that's it. And to have meaning and purpose means that you have to be able to at least pursue an education or an employment that actually helps you find that kind of meaning in your society. So I think it intersects across all services, but community support services, I think, is kind of the all-encompassing. So I think we touch all those bases.
Amy Banco?
I was just going to add very quickly, listening to the presenters, we are all focused on those social determinants of health in some way or capacity, supporting different populations, supporting different types of practitioners, and building the social determinants of health for the folks that we're working with. And that was very, very apparent to me as a common theme or thread.
Thank you, Amy. Well, thank you all for your time. Thanks to the panelists for your incredible work that you're doing, advancing each of these areas, looking forward and identifying ways that we can all do a better job at supporting individuals living with mental health conditions. So thank you, and thanks to those of you who have joined. We really appreciate it. I dropped in the chat, and I'll do it again here real quick, the link to the survey. If you can take a moment to complete that, we would appreciate it. And we have another brief break. Let's see if I can, do we have a break? Maybe we don't have a break. I'm trying to look at the agenda quickly. I think we go directly into our next session, which is the final session other than the closing, using acceptance and commitment training to go from self-care to community care. So if you want to leave us here and join us in the next session, that would be wonderful. Thanks again to our panelists.